Hello and welcome to our presentation. This presentation is created by Amber, Keith, Sabrina, Emily, and Reedy. In this presentation, we will be talking about chronic obstructive pulmonary disease, also known as COPD. COPD is a chronic inflammatory lung disease that causes obstructed airflow from the lungs. And in this presentation, we will be discussing the pathophysiology of COPD, the causes, the signs and symptoms, the population that's affected by it, the nursing management, and finally some resources that help patients with COPD. COPD it's a makeup of two conditions: chronic bronchitis and emphysema. In chronic bronchitis, the airway gets irritated by noxious particles from smoke or other pollutants, which results in inflammation and hypersecretion of mucus, as seen in the image where the airway lumen of the normal bronchus is wide and the airway lumen of someone with chronic bronchitis is very narrow, which makes it difficult for oxygen to pass through the lumen. The constant irritation to the airway in patients with long history of smoking, the mucus secretion will increase, causing mucus plugs. This will also reduce ciliary functions, which increase chances of getting respiratory infections. The hallmark sign of chronic bronchitis is long-term cough with sputum. On the other hand, we have emphysema. In emphysema, the air sacs at the end of the bronchioles, known as the alveoli, become damaged due to long-term exposure to pollutants. The alveoli is where the oxygen and carbon dioxide exchange occurs. In patients with emphysema, these air sacs become distended. Then they lose their ability to recoil, or they lose the ability of elasticity, which impairs the oxygen and carbon dioxide exchange. So in individuals with emphysema, they will have trouble exhaling, which leads to air trapping in lungs. So what causes COPD? The number one risk factor for COPD is smoking. Cigarette contains 43 known cancer-causing elements, including nicotine, tar, ammonia, carbon monoxide, hydrogen cyanide, and many more. These elements injure the airway and the lungs, making it difficult for the air to move in and out of the lungs. Continuous cigarette smoking can also cause COPD flare-ups or exacerbation. Other causes include living or working in areas with high level of air pollution, which causes long-term exposure to pollutants and irritate airway and lead to COPD. Family history of pulmonary disease may increase chances of getting COPD. Substance abuse with substances that can be smoked or inhaled can be irritants to the lungs. Lastly, individuals that are deficit in alpha-1 antitrypsin A1AD can get COPD because A1AD is an enzyme that protects the lung tissue from injury. Lack of this enzyme will increase chances of patients to acquire COPD. So what are some signs and symptoms? Most symptoms occur in 3rd to 5th decade of life due to that long-term exposure to pollutants that causes COPD. The symptoms include shortness of breath due to the decreased level of oxygen reaching to the lungs. Upon auscultation, it is also common to hear wheezing due to the inflamed airways. Some people with COPD may also have auditory wheezing. Cough, which is a hallmark sign of chronic bronchitis, to clear the airway of the mucus. Frequent respiratory infection due to the decreased defense mechanism in respiratory system. Fatigue and activity intolerance due to the decreased amount of oxygen available to be utilized. The population affected by COPD. Currently, an estimated of 32 million people in United States are diagnosed with COPD. 14% of adults between ages 40 to 79 have COPD. As discussed previously, smoking is the number one risk factor of COPD. Middle-aged and older adults are more likely to get it. Individuals living in areas with high air pollution are also at risk of getting COPD. Exacerbation and nursing management. When a patient with COPD experiences an acute exacerbation or a flare-up, the patient will most likely need to be hospitalized. Most common nursing management intervention for these patients would include a discussion of onset and duration of current symptoms, history of smoking or occupational exposure, and other lung and heart diseases. Auscultations of lung may identify wheezes, rales, rhonchi, or decreased breath sounds due to the inflammation in the airway and lungs. Pertinent labs may include arterial blood gases, complete blood count, and a complete metabolic panel to establish a baseline and monitor improvement or decline. ECG can be ordered to rule out cardiac involvement or pulmonary hypertension. Treatment goals are to promote optimal respiratory status and reduce risk of complications such as pulmonary hypertension or pneumothorax. Monitor vital signs, especially oxygen saturation and respiratory rate, and perform focused respiratory assessment throughout the shift. Encourage fluids, at least 1200 ml a day, and monitor input and output. Elevate head of the bed 30 degrees to improve breathing and reduce complication of respiratory distress. Provide oxygen as ordered. Administer prescribed bronchodilators, antibiotics, and inhaled corticosteroids as ordered. Provide medications as ordered to open up the airway, decrease inflammation, and prevent or treat respiratory infections. Non-invasive positive pressure ventilations or NPPV, such as CPAP or BiPAP, may be required in acute exacerbation to help with ventilation or oxygenation. Teach patients diaphragmatic breathing techniques and pursed lips breathing techniques. Promote rest periods after procedures. Request a referral to pulmonary rehabilitation to help patients manage their respiratory issues. Encourage patients to improve their activity tolerance in order to perform ADLs and promote independence. Provide emotional support to reduce anxiety. Encourage cessation of smoking and other contributing factors. Inform patient on importance of medication compliance after discharge and proper follow-up care with primary provider. Community resources. Support groups and organizations can be a great way to assist people who are dealing with chronic lung disease. A few things found within these resources are breathing techniques, exercises, supplemental oxygen, and home health care. One of such resources is Better Breathers Club. The information about scheduling and the address is provided on the slide. This is a support group for patients with respiratory issues and their caregivers. They provide information on the diagnosis and provide a way to cope with the diagnosis. The second resource is San Joaquin County Asthma and COPD Coalition. The address and the contact information is provided on the slide. This is an alliance that provides information on respiratory conditions and spread awareness of such issues. They help set up resources for patients in need. Some national resources for COPD include American Lung Association Hotline, which provides information on respiratory issues and smoking cessation. The phone number and the hours of operations are provided on the slide. The second resource is COPD Foundation. This association also provides education on COPD. It also provides the latest research found on this condition. The web link is provided on the slide, as well as the contact information. All resources listed in the slides above can help patients and their family members to get familiar with the diagnosis of COPD and receive assistance in managing their diagnosis. This is the end of this presentation. Thank you for watching this presentation.